Hello, everyone. It's live with CCO. We're on episode number 66. You know, we have questions that come in, and we want to just briefly give you some insight and educate you on how to do some research when you have questions. The question that we wanted to cover is a basic principle with um, ICD-10 coding. The question is first listed or principal diagnosis. How do we determine which to use? It's important to know that the terms are somewhat interchangeable for inpatient and outpatient, uh, it- but you have to understand what they mean and their purpose. Otherwise, you might, if you say the wrong thing for inpatient or outpatient, somebody might bulk at it and say, "Oh, well, that's really a principal diagnosis, not a first listed diagnosis." But honestly, what you're doing is you're determining which code gets sequenced first and billed out first. If we look at a short definition, uh, we first need to see what's the purpose or the use. Now, I took the definition, the long definition, and just kind of tried to shorten it and comprise it into what does it actually mean? And when you look at primary versus principal diagnosis, the primary diagnosis is the most important diagnosis of the visit. Now, when you look at inpatient, then that could change daily. So, day 2 that the provider goes in and does these rounds and they're doing progress notes. What is the most important diagnosis that day that they're dealing with? The next day may be a completely different diagnosis. So, what you're going to do in inpatient is review those every single day. And you are also considering things like DRGs. We're not going to talk about those. There are resources, and we talked about those. We may talk about those more in depth at another time. Principal diagnosis is going to be why the patient was admitted or why they did uh, the study or testing, diagnostic, or even any type of evaluations and things. Or, why was the patient admitted? The cause of that. And you may not know that right away either. They may have multiple diagnoses. Most of the time, though, the principal and primary and inpatient are the same diagnosis, but it doesn't have to be that way. Now, it is also noteworthy that it really doesn't matter what the sequencing is that the provider puts in as far as, diagnosis A, B, C, or D. It is really all up to the official guidelines and the coding clinic that we've been given to give us direction whenever there's some black and white areas that we can't call black and white that become gray or muddied. That's their purpose of the coding clinic. And one of the key components of your certification, or if you're getting ready to test for your certification, is understanding those official guidelines, both for all of the code sets that you're dealing with. Principal and primary diagnoses, a lot of times, especially inpatient, can be the same diagnosis. When we look at outpatient, what was the reason the patient was seen for that day? Can there be multiple conditions that the patient was seen for that day? Yes, just like in inpatient. So then we look at What is the diagnosis that caused the most medical decision making? That would be the number one diagnosis. If there's multiple that are equal um, when you go to look at them. Can Z codes be used as first listed or principal diagnoses? Absolutely, they can be. Not all of them, but let's look at the different ones that could be. And I didn't pull out the codes and give you code ranges and everything. I just broke down the purpose of the Z code. So if we have a diagnosis and there is a condition that's getting resolved, then it might be an injury, chronic condition, aftercare. Those all can be used as the purpose for the patient to be there that day. What if it's for therapy or chemotherapy, immunotherapy? Don't just think like physical therapy. Often the patient needs to be seen not because they're sick, but because of another specific reason. And those are broken down here in is pre-employment exams, recruitment to the armed forces. We don't think of those. What about school physicals, administrative exams like pre-employment exams? Did I already mention that? Then also, they mention plastic and reconstructive surgery. Say a patient goes in and has bilateral mastectomies and they're doing the reconstruction of the breast. So, in other words, there's really not anything wrong, but they have to follow the care. And then don't forget the status of newborn babies. We would use a Z code for that. There's nothing wrong with the baby, but we do have to cover the status code. I found a great article that was written by Audrey Howard. She's an RHIA with a HEMA, and she mentioned multiple diagnoses, how she determines the principal diagnosis when there's multiple diagnoses that carry equal weight. And I really, really like the statement that she made, so much so that I put the statement out here for us to look at. And then I want to take us out to where the article was written for 3M. And I want to just show you some of the examples that she gave here. I could easily have just, give her attribution and put it on the slide deck. But again, this is just a little tip of how you can do some research and how you would navigate an article per se and get examples, and hopefully that would assist you in understanding. So, what Audrey says is that in her opinion, one of the hardest things she does when dealing with the coding for inpatient is to get that principal diagnosis. And she goes on to state that it's not simply just assigning the code to whatever was documented, the documented diagnosis is. There could be multiple diagnoses. She states it takes critical thinking to ascertain the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. This is a direct definition from the Uniform Hospital Discharge Data Set, and that is abbreviated UHDDS. You may be familiar with that. If you're dealing with inpatient coding, then you probably are. She also goes on to talk about the AHA's coding clinic that many of you probably use often, and they have um, education or what they've determined as guidelines when you get into those gray areas. If you don't already have coding clinic, your employer may offer coding clinic for you. If you are working as a coder and you don't know if you have access to coding clinic, you might go ahead and ask. It may be available and you didn't even realize it. There is really not a shortcut. You're going to have to put in the homework and look at all of the information to determine, especially from day to day, that it can change is what's the diagnosis for that day. You got to go through all the reports. You got to go through the provider documentation. A lot of times there's multiple providers that you're dealing with when in the inpatient world. And you have to look at several conditions happening at once most of the time to come up with one diagnosis out of all of the diagnoses. So let me just pull her no, quickly. Let me pull that article over from 3M. I want to make sure that you're able to see it well enough. So I'm gonna see if I need to make this a little bit bigger. The link I did put in the resource slide at the end of the slide deck so that you can have access to that, and I hope it's beneficial to you. So she wrote this back in June of 2020, but it's still applicable for today. And this is the where I got her discussing that. Then she gives examples of how she determines what is going to be that diagnosis. She says, I ask myself these questions, and that's another reason why she resonated with me when I read this article, because I'm always telling myself, and you have to ask yourself this question, and then this question, and then that'll give you the answer. You'll be able to break it down and determine. The first thing is, did this condition necessitate, excuse me, inpatient admission? And then, would the patient have been admitted to the inpatient uh, setting for this condition? So, was it the diabetes? Was it the COPD exacerbation? Was it the pneumonia with an exacerbation, etc.? Right? Then go on to say, did this condition meet the admission criteria? And was the patient sick enough? And was the treatment significant enough? So, in other words, the patient may have diabetes, but the reason that they were admitted, what was complicating the problem, the reason the patient just couldn't go home was the exacerbation of their COPD. And then, could this condition stand alone as the reason for the admission? So, go through this checklist, ask yourself when you're doing inpatient coding those questions. Now she gives an example. So let's look at this not and then we're going to look at this briefly because you can go out and spend more time. But she gives the example of a 65-year-old female. She goes to the ER and she has a chief complaint, which are signs and symptoms of weakness, fatigue, shortness of breath, exertion for the past week. It was combined, or she also complained of dysuria for the past month. The patient's alert, cooperative, no apparent distress, without fever or chills. Her chest was clear bilateral with no rales, rhonchi, or wheezing. No accessory muscles, stridor. So, in other words, they're ruling out everything for a lung condition. And then her COVID-19 test came back negative. She had no known exposure. And she was noted to have a +3 bilateral pitting edema up to the knee. Okay, now that takes you in a different avenue. So, we got the lungs are kind of okay. Something's happened with the heart. The following table shows a summary of pertinent information. So, what did they do? They said she had the signs and symptoms of an upper respiratory infection, possibly could be sepsis. And so they listed off the signs and symptoms, all the lab tests, and the treatment. They put her on IV antibiotic right away. She could condition deep vein thrombosis because she had the bilateral pitting edema. They did ultrasound, etc. All those tests. They did heparin and Eliquis. Then pulmonary embolism, not documented by the provider though, and that could explain the shortness of breath. Then they go on and review the lab tests, the heparin that they used, and Eliquis. And then she ultimately puts in there that the final diagnoses included the UTI and the DVT. Sepsis was ruled out. So when you break that all down, what did she go with? Based on this circumstances, the only option for principal diagnosis was the UTI. A query related to pulmonary embolism would have been appropriate, etc., because the DVT was not supported as a principal diagnosis. And then again, I'll let you read the rest of that, but she also gives uh, uh, examples of worsening kidney function and going from one facility to another. I really, really enjoyed that article. I thought she explained it very well, and I encourage you to take advantages of searching articles and such as that when they come from a reputable source. 3M would be a reputable source. Her credential tells you she's a reputable source, and she has experience in this realm. What about outpatient coding? Now, this is the way I like to do it, just the way she did. Ask yourself, what is the underlying condition that the patient has, and what's the etiology or manifestations of the condition? So I gave you an example. We've got Mrs. Busy. Now I made this really simple. She's seen today for new onset foot pain determined to be as a result of PVD. This is a complication of her diabetes. Thank you, provider, for mentioning that and telling us what type of diabetes she has. So they are going to put her on gabapentin and they're going to refill her insulin. So that tells us that we would have had 3 diagnoses if PVD wasn't a had that relationship with diabetes. So we get to use a combo code. So we're able to code the E11.51 type 2 diabetes with diabetic peripheral angiopathy, which is PVD. They don't have gangrene, and also she's on insulin. Now we wouldn't use the Z79.4 as the first diagnosis because even though he refilled her insulin, and that may have been one of the reasons that she was there to get more refills on her insulin. Still, what caused the most consideration and concern and medical decision making? It was the fact that she had a new sign and symptom, and he gave her a new diagnosis. PVD. It also was complicating her diabetes. So we've got two diagnoses going there. So E11.51 would be that first listed diagnosis. I'm seeing here a question. Let me just jump over here and look really quickly. Good evening. I'm having some trouble with diagnosing 4 to 5 for one patient. I'm having issues with that portion of my classes. And I can give you a quick little tip, Matilda. Again, why was the patient seen that day? That's usually the first listed diagnosis. However, if there is a diagnosis that is uh, more severe, you would use that first. However, you still have to follow the guidelines. And if you're in a course, that's what they're driving home. Also, this pertains to CPT. There's sequencing of CPT codes. A lot of students get confused with repairs sometime on removals of lesions and things will get sequenced before the actual removal because it's more complex than just cutting off that lesion. No, they have to do a repair that takes more time and underpinning and stuff like that. So again, follow what the guidelines state. If the guidelines use the term code first, then you know that code is sequenced first. If they use the term use in addition, that code is sequenced second. We have lots of practice, so feel free to jump in and look at a lot of our YouTube videos regarding that. Let's see. I think there was another comment. My past, if patient had 3 or 4 diagnoses, list them all each day. Inpatient status, follow the ICD-10 rules related to add a diagnosis or excludes rules 1 in coder and stuff will inform you. That is correct, Jane. So it's not like you're just thrown out there to do all of this guesswork. You have the tools, especially in inpatient, to be able to determine which is the proper code to work with. Uh, what is the doorknob diagnosis? I've heard that expression. I I'm not sure about doorknob diagnosis. I think that refers to when the provider first opens up the door in the patient's room, that doorknob, what they're thinking they're going to see. Yeah. And, Ma Matilda, just go to our YouTube channel, Medical Coding Cert, which you can find it very easily because you're watching a video on YouTube, and you'll be able to, just hit the little bell and, or subscribe, and you'll be able to get it. Plus, it looks like they're on top of it, and they've put it in the search bar. So, let's now look at another example that, real quickly we have Mr. Smart, and he's going to the doctor, his PCP, and he's being followed for his hypertension, his COPD, his prostate cancer, which is followed by oncology. And today he states noted is a productive cough with green sputum, nasal congestion is present, URI is the diagnosis, the CPAC is the plan of care that's sent in to the pharmacy, and he tells him to get an over-the-counter ocean spray and use that twice a day. So we have 3 diagnoses. We have COPD, we have hypertension, and we have prostate cancer. Now, you would assume if you're talking about severity of disease prostate or processes, prostate cancer would trump everything else because that's a more severe active prostate cancer. That should always be number 1. However, that's being managed by oncology. And even though that's part of the medical decision making that the provider is doing that day, you have to think, okay, we're in active treatment for prostate cancer or whatever the treatment is. Uh, we have a patient that actively has cancer, but they also have hypertension, and a lot of medications that you give a patient, even over the counter, can affect hypertension medication. But what is uh, the reason we don't even know the reason the patient came in per se, right? He's being followed with these 3 diagnoses. But the patient does have a productive cough. The sputum is green. They're probably sending it off to have it checked to see what the organism is. In the meantime, the patient also obviously has some type of a cold or something going on. So they give them a respiratory infection diagnosis, and we have the J44.0 because it's not regular COPD. We have an exacerbation going on. And also, don't worry about it being lower respiratory infection versus upper respiratory infection. Uh, and then next, the most severe out of the other 2 would be the fact that the patient has prostate cancer, C61, and oh, by the way, they do have hypertension. Okay, so that is the sequencing of today's visit. Now, if they were having complications due to the uh, prostate cancer or any of the treatments for the prostate cancer, say nausea, vomiting as a result, or dehydration due to the chemotherapy, etc., that changes the sequencing. Okay. But again, just keeping it short and sweet with the information that you're provided, it would be the COPD first, the neoplasm after that, the prostate cancer, and then anything else that followed in the sequence from there. All right, that's it, guys. I did link the that for you on the 3M article. It was so good. I didn't take time to go look her up, but I think I will and see if I can get more information about her. And then let's see, EMR trauma gun shooting. Let's see, Jane says, I also heard if a patient smokes or does pot and has chronic conditions of heart, hypertension, etc., the diagnosed C72 or C if current or past cigarette habit. Well, you would put those, but they wouldn't be first listed diagnoses for the patient. Let me just see if you had another question in there that I missed. I tell you what, it's wacky when the doctor adds some slang diagnosis when you have to really pay attention to his notations or his query him. Yes, that is correct. Yeah, and then could you review? Okay. That's it, I think, guys. If casual relationship, if a provider would have just said it had type 2 diabetes and now has PVD, that still there is a guideline in there, DG, that you combine those when they're documented together. Doesn't matter that it says with or and. You PVD and diabetes has a causal relationship, and so therefore that changes the E1 1.9 to E1 1.5 1, I think, and you don't use the I7 3.9 PVD code because it's already explained in the combo code. That is a part of the diabetic coding, and you'll be tested heavily on that in the exams. All right, thank you guys. Oh, another question. If a patient has trauma gun shooting and the EMR doc supposed to put reason if related to a crime or if this is kept confidential? Oh, okay. There are codes to explain that the patient has a gunshot wound and the circumstances surrounding that gunshot wound. Now, it doesn't matter if it's meant to be kept confidential. The medical record is confidential. So if the provider documents, you can't code anything unless it's documented because you're translating for the statistics. And so if you say that it was if the provider states that it is a domestic disturbance and the patient was shot, or if they were walking down the street and the patient was shot, or if it was a mass shooting, if the patient was shot by a police officer, if the patient is a police officer and was shot, there are codes to describe all of those scenarios and much more. And so if it's documented, you code it, and it is confidential because it's part of the medical record. But it is important to do that. Sandra says there's no meat for the prostate cancer. Yes, there is. These patients followed by oncology. That's all you have to say. And it's not for risk adjustment, so it would be okay. Oh, that makes sense. Privacy of medical record is maintained. Correct. Yep, Sandra. Very good. Yeah. Sandra's a CRC. Thank you, Sandra, for joining us. I'm so glad that you're here because I am a big risk adjustment person as well. So very good. And don't forget that more information can be found in the CCO Club. And if you want to know more, just go to cco.us/club. If you're watching us on YouTube, don't forget to subscribe so that you can see our other videos and know when we are about to have a live video. We do all of these live. Some we keep on YouTube and some we put exclusively into the club. Don't forget that we have fabulous courses if you want more information. But if there's a question that you have and that you want us to unpack and talk about it, go to the cco.us/topic-request, and we will absolutely put it in this format and hopefully answer your questions. All right. Thanks, guys. See you next time.
Our online medical coding course was created specifically for beginners to learn everything they need about medical coding. The course includes a personal coach, 9 months of access, 24/7 online videos, transcripts, and exams. You can learn more about our medical coding course at www.cco.us/PBC.